Hi, my name is Atif Darwish, Professor of OBGYN, Asyut University, Egypt. The talk of today is about adenomyosis uteri, and previous publications and previous textbooks mention that adenomyosis is a form of endometriosis. It is internal endometriosis, and the well-known endometriosis, which is pelvic endometriosis, is called external endometriosis. This is an old classification, and in the modern practice does not exist because they are not similar entities. They are different, completely different in the pathogenic pathway, in the type of patient, symptomatology, lines of management, and the complications, despite being associated together in many cases. Up to 90% or 80 to 90% of cases you may find endometriosis and adenomyosis, but still there are many differences between these two entities. So we have to discuss adenomyosis as a separate disease, not linked to pelvic endometriosis. Adenomyosis is heterotropic endometrium, like heterotropic pregnancy, which means intrauterine pregnancy and extrauterine pregnancy. So we have endometrium intrauterine, lining the normal endometrial cavity, and extraendometrial, which is embedded inside the myometrium. And the adjacent myometrium is not innocent. It shows hyperplasia, so the uterus will be enlarged in size due to the muscle hyperplasia or myometrial hyperplasia and the implanted endometrial tissues. Why this occurs? This occurs because many theories explaining this, but the commonest and most logic theory is that the zona bisalis, which is the basic layer of the endometrium, invaginate inside the myometrium due to destruction or alteration or interruption of the junctional zone. This is a basic etiology, or the most common explanation of why the endometrium left its place and goes inside the myometrium. We should know what's junctional zone. Junctional zone anatomically is the inner third of the myometrium, near to the endometrium. The outer third is an inert part of the myometrium. The inner third is the active part of the myometrium. It is architecturally and functionally different from the outer third, two-thirds. It is the origin of myometrial contractions, which are responsible for different mechanisms in infertility and in bleeding, as proved by thin MRI studies. Functionally, the junctional zone is a highly specialized hormone responsive structure located in the inner third of the myometrium. So it is not just the inner third, it is a very active inner third with a lot of production of hormones and so on. It's very important layer, and thanks to MRI we diagnosed this part of the uterus, and we concentrated on it in this very important topic. So the topic of adenomyosis has been improved markedly in literature after the introduction of MRI evaluation of the myometrium and its division into inner third, which is the active part, and the outer two-thirds. Now, what happens with a patient with invagination of the endometrium inside the myometrium? This is common in patients with a history of trauma to the endomyometrial junction. When this trauma occurs with childbirth, so this disease is common in multiparous women, with cesarean section, of course, with prior myomectomy or other hysterectomy or other uterine operations, with termination of pregnancy, evacuation, curettage, and so on. So any intervention with the normal endomyometrial junction and destruction or alteration of this junctional zone by intervention, whether natural or iatrogenic, is the cause of the adenomyosis. And this is actually one of the theories explaining why adenomyosis occur. Why does it occur? So it is called tissue injury and repair theory. Tissue injury and repair theory. But others mention that the adenomyosis is an estrogen-dependent disease, so it is commonly seen in patients who have a lot of estrogen. Reproductive age is common around 30-year-old, and in women with early menarche, short menstrual cycles, obese with tamoxifen use. And one of the suggested possibilities, the occurrence of depression and use of antidepressants in some studies. Now what happens in the uterus? If you examine the patient or see her by ultrasonography, you will find the measurements of the uterus increase, and this is the gross appearance of the uterus. If you do hysterectomy, and this is the hysterectomy specimen, the myometrium is enlarged, hypertrophied, whether symmetric or asymmetric, and you will see glands inside with foci, with hemorrhage inside, and this is the gross appearance of the uterus, which does not mistaken with other abnormalities. If you take a biopsy, you will see endometrial glands and stroma surrounded by hyperplastic myometrium, which is adenomyosis. In most cases, around more than 50% of cases, the adenomyosis is diffuse in the whole uterus, but sometimes it is cystic in 4% or 5% of cases. Sometimes it is localized, nodular in around 30% of cases, and sclerotic in around 13% of cases. So you may see diffuse adenomyosis, you may see localized, you may see cystic or sclerotic adenomyosis. Now, is it a frequent disease? Can I see it in my day practice? Yes, you can see it if you concentrate on this disease, if you put it in your mind. This depends on your clinical sense. During examination of the uteri, you should train yourself on the examination of normal sized uterus and abnormal sized uterus. What's the cause of abnormality? You have to search for this. This is number one. Number two, if you do ultrasonography, you can see it in around 20% of cases by ultrasonography. If you are dealing with an infertile patient and preparing her for assisted reproductive technique, you may find a prevalence of up to 25% of cases. Patients with endometriosis, up to 80% of cases, you may see adenomyosis in those cases. And if you do hysterectomy, don't ignore to open the uterus to see what's inside the cavity. And what about the myometrium? You can see in the hysterectomy specimen adenomyosis in the uterus in up to 35% of cases. So you can diagnose adenomyosis frequently if you put it in mind. Nowadays, we observed increased prevalence of adenomyosis. Why? Because of increased diagnostic tools of adenomyosis. Nowadays, ultrasonography, whether two-dimensional or three-dimensional ultrasonography, can easily diagnose adenomyosis. MRI played a very important role in understanding of adenomyosis and its mechanism, and this is very important. Now we have a patient at the outpatient clinic with adenomyosis. Do all patients will present with complaints? No. 1/3 of our patients will be asymptomatic, no symptomatology. Just 2/3 will start to complain. Complaint will be pain. In most of cases, this pain may be chronic pelvic pain, more than 6 months, acute pelvic pain, which is characteristically will be piercing, scalpel-like pelvic pain, very painful, very agonizing, and sometimes the pain is dysmenorrhea, congestive dysmenorrhea, dyspareunia, dysuria, dyschezia, and muscle pain, generalized muscle pain due to anemia and exhaustion of this pain, and bone pain also due to anemia and generalized general bad condition, because this disease affects the patient's quality of life will be impaired, and it definitely has a negative impact on the woman's quality of life. Another category of complaints will be abnormal uterine bleeding, and this is seen in the palm coin FIGO classification, and P is polyp, A is adenomyosis. So it has been put by the FIGO as one of the causes of abnormal uterine bleeding, and the abnormality may be menorrhagia, spotting, metrorrhagia, and you may find combination of pain and abnormal uterine bleeding together. Other symptoms may be irritable bowel syndrome, irregular bowel movements, nausea, fatigue, mood changes, insomnia, and depression due to the heavy bleeding, due to severe pain, agonizing, piercing pain. And you may have a case with infertility and adenomyosis, or you may have a case with bad obstetric history due to preterm labor, due to abortions, due to preeclampsia, due to any bad obstetric abnormality outcome, also can be attributed to adenomyosis. Regarding infertility, how adenomyosis would be seen as a cause of infertility? This can be explained by abnormality of the uterotubal transport inside the uterus. So transport of sperms will be impaired due to increased intrauterine pressure, due to dysfunctional hyperperistalsis, due to anatomic distortion of the uterine cavity. So the process of fertilization will be affected due to abnormal ascent of the sperms and transportation to the ampullary part of the fallopian tube. Another explanation for the infertile cases is the altered endometrial receptivity by the uterine contractions, by the increased intrauterine pressure, which may lead to impaired implantation. So infertility can occur in cases with adenomyosis as well. What about the pregnancy outcome? I told you it can lead to preterm labor, premature rupture membranes, increased risk of cesarean-section delivery, small for gestational age, postpartum hemorrhage, fetal malpresentation, second trimester miscarriage, preeclampsia, and placental malposition. All these are some studies publishing the adverse effect of adenomyosis on pregnancy outcome. May be explained by inflammatory process associated with adenomyosis, increased myometrial prostaglandins, altered contractility and peristalsis, or increased uterine intrauterine pressure, as I told you before. Now we have a case in the outpatient clinic. What can I see in the clinical examination? You should concentrate on the uterus. It is a disease of the uterus. So examination you may find a large sized uterus, which is called bulky uterus, and characteristically it is very tender, extremely tender when you do BV examination, and this tenderness is characteristic for adenomyosis. Don't forget to test a case with adenomyosis to see how much pain expressed on the faces of this patient, and this is called Halpin's sign. Halpin's sign is severe agonizing pain on bimanual examination of the uterus. This is very important in addition to increased size. So we have to examine the patient by two-dimensional ultrasonography, by transvaginal. You may see the myometrium enlarged symmetrically or asymmetrically. The uterus is globular in shape with thickness and characteristically trabeculation or of irradiation inside, like fan shape inside the myometrium. So these are possibilities of ultrasonographic findings, include asymmetrical thickening of the uterus, intramyometrial cysts or hyperechogenic islands or both, fan-shaped shadowing, myometrial due to shadowing due to the gland branching inside the myometrium, myometrial echogenic subendometrial lines and buds, translesional vascularity, and irregular or interrupted junctional zone. And this is a picture of localized lesion with areas of decreased echogenicity and heterogeneity of the myometrium, which is seen in more than 75% of cases. If you use your Doppler machine, you will find increased myometrial vascularity in cases of adenomyosis, whether localized or diffuse. The increased myometrial vascularity is a characteristic Doppler finding in all cases. Again, MRI is the key of diagnosing adenomyosis, and It is the tool that helped us to understand adenomyosis in the current practice well. In the mid-sagittal slice 2T, you will find normal endometrium appears as homogeneously hyperintense due to increased fluid content, vascular content inside the endometrium, and in the adjacent myometrium there is decreased vascularity or water content, which is the inner 1/3 of the myometrium, which is the junctional zone hypointense area. Again, the MRI, you can see some bright foci seen in areas with abnormal low signal intensity within the myometrium in approximately 50% of cases. These foci may be heterotropic endometrial tissue, cystic dilatation of heterotropic glands, or hemorrhagic foci inside the myometrium as seen in these pictures. Now, what is the diagnostic criteria for adenomyosis by MRI? The MRI mentions that junctional zone, which is the active inner third of the myometrium, should be less than 8 mm in normal uteri. If it is more than 8 mm, it is a case of adenomyosis. You can diagnose adenomyosis if the junctional zone is less than 8 mm, provided linear striations are seen inside this area. If not seen, it is not a case of adenomyosis. So the cutoff level is 8 mm. If it is less, it is not adenomyosis. If it is more, between 8 and 12, it is adenomyosis. You may find adenomyosis by when you are doing laparoscopy for another cause like pain evaluation or infertility assessment. And adenomyosis, if you do laparoscopy, the first point to alarm the adenomyosis diagnosis by laparoscopy is the fixed RVF uterus, the heavy uterus, the bulky uterus by ultrasonography, by laparoscopy, and you have to push the uterus anteriorly to the uterovesical pouch to see the Douglas pouch because it cannot be seen by the trocar in the umbilicus unless you use another instrument. Sometimes the uterus is symmetrically or asymmetrically enlarged, and you may, if you have a previous ultrasonographic diagnosis of a cyst inside the uterus, you may make hysterotomy or incision of the uterus by a needle, and you may see chocolate material of the retained menstrual blood inside the endometriotic tissues inside the uterus, which are adenomyosis, and the hemorrhagic cysts can be drained by laparoscopy. Also, if you inject dye inside the cervical canal to test for tubal patency, the dye may go to the myometrium, not to the fallopian tube or with the fallopian tube. This is because of the invagination of the endometrium from the endometrial cavity into the myometrium, and this is called the blue sign, which is a pseudo widening from the adenomyosis, and this is a sign published by some authors. So these are the criteria by laparoscopy. You can see a localized cyst by laparoscopy. If you have a good sonographic diagnosis, preoperatively you can incise it and drain what's inside. This is a big adenomyotic uterus, as I told you. Now we will do hysteroscopy for this case because she is an infertility case or abnormal uterine bleeding case. We'd like to evaluate what's inside the uterine cavity. If you go by hysteroscopy, you can see some abnormalities that may alarm the diagnosis of adenomyosis, like superficial openings of the endometrial cavity suggesting disruption of endomyometrial junction, endometrial hypervascularity, which is seen if you minimize the pressure inside the uterine cavity a little bit, and you can see cystic hemorrhagic lesions bulging inside the endometrial cavity, and sometimes you can open these lesions as seen in these pictures. You can open them by microneedle to drain the hemorrhagic content of these cystic lesions. All these possibilities are guided by a We have an old publication on using hysteroscopy to take a biopsy to diagnose adenomyosis as well.